Scatter control and beam restriction. This is part 1 from chapter 12 in the Johnston and Faber book, Essentials of Radiographic Physics and Imaging. Scatter radiation is primarily the result of the Compton interaction, in which the incoming X-ray photon is going to lose energy and change directions. There's two major factors that affect the amount of scatter radiation produced and exiting the patient: the volume of the tissue irradiated and the kVp, which is the kilovoltage peak. The volume of tissue depends on the thickness of the part and the X-ray beam field size. Increasing the volume of tissue irradiated is going to result in increased scatter production. And then also using a higher kVp increases the X-ray transmission, and it's going to reduce its overall absorption, which is the photoelectric interaction. A higher kVp also increases the energy of scatter radiation exiting the patient. Compton scattering is one of the most prevalent interactions between X-ray photons and the human body in general diagnostic imaging, and it's also responsible for most of the scatter that fogs the image. So we want to get rid of the scatter that fogs the image, but we also want to reduce the patient's radiation exposure. The probability of Compton scattering does not depend on the atomic number of the atoms involved. Compton scattering may occur in both soft tissue and bone. The probability of Compton scattering is related to the energy of the photon. As X-ray photon energy increases, the probability of that photon penetrating the tissue without interaction increases. With this increase in photon energy, the likelihood of Compton interactions relative to the PE or photoelectric interactions will also increase. Scatter radiation must definitely be controlled. Scatter radiation provides no useful information about the anatomic area of interest. Controlling the amount of scatter radiation produced in the patient and ultimately reaching the IR is essential in creating a diagnostic quality image. Scatter radiation is detrimental to radiographic quality because it adds unwanted exposure, which is the fog, to the image without adding any patient information. Digital IRs are more sensitive to lower energy levels of radiation, such as scatter, and this is what results in increased fog in the image, or we call it image fog. Additionally, scatter radiation decreases radiographic contrast. However, radiographic contrast can be computer manipulated by changing the window width. And remember, we do that with the mouse for post-processing. You move your mouse from side to side and you can change the window width, which is changing the radiographic contrast. Increased scattered radiation, either produced within the patient or higher energy scatter exiting the patient, affects the exposure to the patient and anyone within close proximity to the patient or to the primary beam. Therefore, the radiographer must act to minimize the amount of scatter radiation produced and reaching the image receptor. The greater the volume of tissue that is irradiated because of part thickness or the X-ray beam field size, the greater the amount of scatter radiation produced. The higher the kVp you use, the greater the energy of scattered X-rays exiting the patient. Beam restricting devices and radiographic grids, which we'll talk about more next week, these are tools that the radiographer can use to limit the amount of scatter radiation that affects the radiographic image and exposure to the patient and the RT. Beam restricting devices decrease the X-ray beam field size. They decrease the amount of tissue being irradiated. And then they also, because of that, reduce the amount of scatter radiation produced. The radiographic grids are used to improve radiographic image quality because they absorb the scatter radiation that exits from the patient. And this will reduce the amount of scatter reaching the IR. Grids do nothing to prevent scatter production. They merely just reduce the amount of scatter because they absorb the scatter, so they reduce the amount of scatter reaching the IR. It is up to you, the radiographer, to limit the X-ray beam field size to the anatomic area of interest. So beam restriction serves two purposes. It limits patient exposure and reduces the amount of scatter radiation produced within the patient. The unrestricted primary beam is cone-shaped, and it's going to project a round field on the patient and the IR. If not restricted, the primary beam goes beyond the boundaries of the anatomic area of interest and the IR size, and this will result in unnecessary patient exposure. Anytime the X-ray field extends beyond the anatomic area of interest, the patient is receiving unnecessary exposure. So limiting the X-ray beam field size is accomplished with a beam restricting device. So this is beam restriction. Located just below the X-ray tube housing is the beam restricting device, and it changes the shape and size of the primary beam. We call it the collimator. The terms beam restriction and collimation are used interchangeably. They refer to a decrease in the size of the projected radiation field. The term collimation, which is used more often than beam restriction, because collimators are the most popular type of beam restricting devices. And that's what you will see going out to clinicals. In the lab, you'll see a collimator. So increasing the collimation means you are decreasing the field size. So you're using more collimation, okay? So more collimation makes your field size smaller. Decreasing collimation means you're not collimating, means you are increasing the field size. So if we put, let's say we put our field size at 14 by 17 for a chest x-ray, and we're not collimating. That means we're decreasing our collimation. And that means that the field size is increased or staying at 14 by 17. Now, if we have a field size of 14 by 17, but we have a small patient or a pediatric patient, we want to increase our collimation to decrease the field size because the patient is small or a pediatric, and we don't need to use the 14 by 17. As collimation increases, the field size decreases, and the quantity of scatter radiation is going to also decrease. As collimation decreases, the field size increases, and the quantity of scatter radiation increases. In addition to decreasing patient dose, beam restricting devices also reduce the amount of scatter produced within the patient, reduces the amount of scatter the IR is exposed to, and then increases the radiographic contrast. The relationship between collimation or the field size and quantity of scatter radiation is seen in this diagram here. You can see on the left side, it's relative intensity of scatter radiation going from 0 all the way up. And then on the bottom of the chart is the field size in square inches. So you can see if we have 8 by 8, it's maybe about 25% of relative intensity. If you go to 14 by 17, it's going to be all the way up to like 100%. So the bigger the field size, you can see, the more scatter radiation. So we always want to make sure and collimate, and decrease your field size as much as you can without obviously cutting off any of the anatomic area of interest. As collimation increases, the field size decreases and the quantity of scatter radiation decreases. As collimation decreases, the field size increases and the quantity of scatter radiation increases. So the size of your field, or the field size, is directly proportional to the scatter radiation. So the larger your field size, more scatter radiation. The smaller your field size, less scatter radiation. Because collimation decreases the X-ray beam field size, there is less scatter radiation produced within the patient, and then also less scatter radiation is going to reach the IR. As collimation increases, the quantity of scatter radiation decreases and radiographic contrast increases. As collimation decreases, the quantity of scatter radiation increases and radiographic contrast decreases. An increase in collimation also affects the number of X-ray photons reaching the IR to produce the latent image. Increasing collimation decreases the number of photons that strike the patient and decreases the amount of scatter radiation produced. Exposure factors should be increased when increasing collimation. For example, when you collimate significantly, so you're changing from an 11 by 14 field size to a small 4-inch diameter cone, the radiographer must increase exposure to compensate for that decrease in the number of X-ray photons. The KVP is typically not increased because it increases the proportion of scatter produced in the patient. So to maintain the exposure to the IR, the mass should be altered. So the mass would be increased. There are several types of beam restricting devices that we will talk about on the next slide to be able to utilize this patient dose decrease and scatter radiation decrease and radiographic contrast increase. There are several types of beam restricting devices available, and what they will do is, for increased collimation, it will decrease the patient dose, decrease scatter radiation, increase radiographic contrast, and the quantum noise increases without the appropriate increase in mass. So if we want to increase our collimation and decrease patient dose, scatter radiation, radiographic contrast, we will have to increase our mass to compensate so that we don't get the quantum noise on the image. And then for X-ray field size, with the X-ray field size, if we're increasing the X-ray field size, which means we are decreasing collimation, the patient dose is going to increase, the scatter is going to increase, radiographic contrast will decrease, and the quantum noise will decrease as well. So there are several types of beam restricting devices to help with that. They differ in sophistication and utility. All beam restricting devices are made of metal or a combination of metals that readily absorb the X-rays, and aluminum is one of those. So we have aperture diaphragm in this picture here, and it is the simplest type of beam restricting device. It is a flat piece of lead that has a hole or an aperture in it. It's commercially made and available, as are those that are homemade, hospital made for specific purposes to radiographic units. The aperture device is easy to use. They're placed directly below the X-ray tube window. It's a diaphragm that can be made by cutting rubberized lead to the size needed to create this, and cutting the center to create the shape and size of the aperture. The aperture's size and shape can be changed. The aperture cannot be adjusted from the designed size. The projected field size is not adjustable. Because of the aperture's proximity to the radiation source, which is the focal spot, a large area of unsharpness surrounds the radiographic image. Aperture diaphragms are still used in some applications, but their use is not as widespread as other types of more common beam restricting devices. You can see in this picture here, because of the aperture's proximity of the focal spot, there's a large area of unsharpness that surrounds the entire radiographic image that we do not want. So that's why the aperture diaphragm is not most commonly used nowadays, as is the other beam restricting devices. Cones and cylinders are shaped differently, but they have many of the same attributes. A cone or cylinder is essentially an aperture diaphragm that has an extended flange attached to it. The flange can vary in length and can be shaped as either a cone or a cylinder. The flange can also be made to telescope, thereby increasing its total length. Like the aperture diaphragms, cones and cylinders are easy to use. They slide onto the tube directly below the window. Cones and cylinders limit the unsharpness surrounding the radiographic image more than the aperture diaphragms do, with cylinders accomplishing this task slightly better than the cones. They are limited in terms of the sizes that are available, and they're not necessarily interchangeable among different tube housings. Cones have a disadvantage compared with cylinders. If the angle of the flange of the cone is greater than the angle of divergence of the primary beam, the base plate or the aperture diaphragm of the cone is the only metal restricting the primary beam, so not much filtration. Therefore, cylinders generally are more useful than cones. Cones and cylinders are almost always made to produce a circular projected field, and they can be used to advantage for some radiographic procedures like the sinus exam, when we just want to see the sinuses. So if you look here at this image, A is not using a cylinder. So we're not really getting all the detail of the sinuses that we want to see. But B is using a cylinder, so you have captured all of the sinuses inside of that cylinder. You always want to make sure that when you are using a cone or a cylinder, that your positioning is perfect and your central ray is perfect, because I can see here on B that they're actually clipping some of the sinuses. They're clipping the maxillary sinuses. So you want to make sure that you are centering perfectly, and you want to include all of the sinuses inside of that circle without clipping anything. Collimators are the most sophisticated, useful, and accepted beam restricting device. They are considered the best beam restricting device available for radiography. Beam restriction accomplished with the use of a collimator is called collimation, and that is what we are used to hearing. The terms collimation and beam restriction are used interchangeably, so they do mean the same thing. A collimator has 2 or 3 sets of lead shutters located immediately below the tube window. The entrance shutters limit the X-ray beam, just like an aperture diaphragm does. 1 or more sets of adjustable lead shutters are located 3 to 7 inches below the tube, and then these shutters consist of longitudinal and lateral leaves or blades, each with its own control. This makes the collimator adjustable in that it can produce projected fields of varying sizes. So we can change the length and the width of the field size. The field shape produced by a collimator is always rectangular or square unless using a lead mask, cone, or a cylinder placed below the collimator. A lead mask is similar to an aperture diaphragm in that it will change the shape and size of the projected X-ray field. Collimators have a white light source and a mirror to project the light field onto the patient. This light is intended to accurately indicate where the primary X-ray beam will be projected during the exposure. In case of failure of this light, an X-ray field measurement guide is present in the front of the collimator. It indicates the projected field size based on the adjusted size of the collimator opening at the SID that you're using. This helps ensure that the radiographer does not open the collimator to produce a field that's larger than the IR. Another problem that may occur is the lack of accuracy of the light field. The mirror that reflects the light down toward the patient or the light bulb itself could be slightly out of position, projecting an inaccuracy of the light field. So it'll be hard to tell exactly where the primary beam is located. There is a means of testing the accuracy of this light field and the location of the center of the projected beam. You have a plastic template that you use with crosshairs, and you put it on the bottom of the collimator to indicate where the center of the primary beam is, or the central ray. This is of great assistance to the radiographer in accurately centering the X-ray field to the patient if we have to use that. An automatic collimator is also called a PBL, or a positive beam limiting device. It automatically limits the size and shape of the primary beam to the size and shape of the IR. So as soon as you put in the IR, it automatically will collimate down to the size and shape of the IR. This is good because it will prevent RTs from making the field size larger than the IR. So this will cut down on patient dose and scatter. So it's a way of protecting the patients from overexposure to the radiation. There is an override mechanism that does allow the radiographer to disengage this feature, and it does allow them to increase the field size if they need to. So whether automatic collimation is used, the radiographer should always be sure that the size of the X-ray field is the same or less than the size of the IR, except for the digital flat panel detectors. When using a flat panel detector, the X-ray field size should be restricted to the anatomic area of interest. The digital IRs are typically 14 by 17 or 17 by 17, and sometimes they are actually larger than the anatomic area of interest. It is therefore even more crucial for the radiographer to collimate appropriately for the imaging procedure so the patient's not exposed to radiation unnecessarily.